We hear about incredible medical breakthroughs all the time, don't we? A new drug discovered, a groundbreaking treatment. It's really a testament to amazing science. But have you ever stopped to think about what happens after that discovery? Does it actually, reach everyone who needs it? Are these wonder drugs truly changing public health? Or is there maybe a gap?
Today, we're doing a deep dive into that very question. We're looking specifically at the fascinating, and yeah, maybe a bit frustrating, journey of some cutting-edge heart failure treatments.
Yeah.
We're focusing on something called quadruple therapy for a condition, heart failure with reduced ejection fraction, or HFrEF. Bit of a mouthful, but it's serious and affects millions.
Right. And our mission today really is to unpack why these therapies, which are genuinely life-saving, often get stuck. Stuck on the past from the research paper to the actual patient. We're looking at a recent research paper that lays out these challenges. And there's some, frankly, surprising insights into the real-world obstacles. It's this paradox, isn't it? Powerful medicine not quite reaching its potential. Absolutely.
Yeah.
So we'll start with the science, understand why these treatments are such a big deal. Then, let's peel back the layers and look at those practical hurdles that stop them getting used everywhere they should be. Okay, let's dig in. This quadruple therapy sounds really promising. What exactly is it, and why is it considered such a breakthrough for heart failure patients?
So fundamentally, it's a multi-drug strategy that's really shifted how we manage HFrEF. The newest piece, and maybe the most exciting, involves a class of drugs called sodium glucose cotransporter 2 inhibitors. SGLT2I for short. We're talking about specific drugs like empagliflozin and dapagliflozin. And what's really key here, something the research emphasizes, is that they're approved for heart failure patients even if they don't have diabetes.
Oh, right, because they started as diabetes drugs.
Exactly, that was their original thing. So this widens their use massively. And the benefits, they're significant. Clinical trials show SGLT2I reduce major adverse cardiovascular events. That means fewer hospital stays for heart failure, lower risk of death from heart issues, even fewer strokes and things like that.
Wow. That's not just tweaking things. That sounds like a major improvement in outcomes.
It really is. We're talking about a fundamental shift, offering a much better outlook for many patients.
So how did these new drugs fit into the picture? Did the official guidelines, the recommendations for doctors, catch up?
They did, yeah. Quite decisively, actually. In April 2022, there was this joint task force, the American Heart Association, American College of Cardiology, Heart Failure Society of America, the big players, they updated their guidelines. And based on all this strong evidence, they recommended SGLT2I as the fourth pillar of what we call guideline-directed medical therapy, or GDMT, for HFrEF.
Fourth pillar. Okay, so what are the other three?
Right, so the four pillars together form the core strategy now. You've got the SGLT2I. Then there are renin-angiotensin system inhibitors, or RAS inhibitors.
Those help relax blood vessels, right?
Mm-hmm.
Take strain off the heart.
Precisely. Then you have beta blockers, BBs, which slow the heart rate, help it pump more efficiently, let it rest a bit more. And the fourth are mineralocorticoid receptor antagonists, MRAs. They block certain hormones that can make heart failure worse, help reduce fluid buildup. So those four classes, used together, optimized, that's the gold standard now for HFrEF.
Okay, imagine having that. A clear, powerful, four-part plan for a condition like heart failure.
Yeah.
It really does sound like a game changer.
Yeah.
So what's the holdup? If it's so good, why isn't it just happening everywhere? What comes next? What are these obstacles? Yeah, this is where it gets really interesting and maybe a bit concerning. If these drugs are such a clear boon and the guidelines are there, why isn't it just rolling out smoothly? What's the catch?
It is fascinating and, frustrating too. Despite how promising the science is, despite the strong guidelines, actually getting these therapies into everyday clinical practice, it remains surprisingly difficult. It's not like flipping a switch just because the evidence is there.
And is this a widespread problem?
It seems to be. The sources we looked at point out that even in places with top-notch medical facilities like the U.S., just getting patients to take their meds consistently, adherence, and getting doctors to fully implement GDMT, these are big hurdles. And the research actually describes the situation as far scarier in low and middle-income countries, where resources are even tighter.
This doesn't sound entirely new, though. Has medicine struggled with this kind of thing before, this lag in adopting new treatments?
Oh, absolutely. There's a stark historical example. ACE inhibitors, one of those other pillars we mentioned, they came out for HFrEF way back in 1990. Now think about this. 10 years later, only about half of primary care doctors were regularly prescribing them, 50%. And it took over 30 years, 3 decades, to get that adoption rate up to around 80%.
30 years, wow.
Yeah.
That's a lifetime for some patients.
It's a staggering delay. And it's not just ACE inhibitors. Other studies have shown it can take almost 20 years for just like 14% of new guidelines to become common practice. So SGLT2I, as amazing as they are, they're entering a system that's just historically slow to change, even for really effective stuff. It's a systemic issue.
Okay, so there's that historical inertia. But for SGLT2I specifically, are there more immediate roadblocks, things stopping them right now?
Definitely. One very practical barrier the research highlights is cost. Specifically, the high out-of-pocket cost for people without insurance or even with inadequate insurance. For many, even knowing a drug could dramatically help them, the cost just puts it out of reach. And without getting higher rates of adoption, getting these drugs to most people who need them, the amazing results from the clinical trials, well, they don't translate into that big public health impact we want to see. The wonder drug effect stays limited if people can't actually get the drug.
Right, the best drug in the world doesn't help if it stays on the shelf. So what's being done? Are there efforts to try and bridge this gap to get these treatments out there? People must be trying things.
Yes, they are. The paper talks about this idea of new promises with old legacies. We have these new tools, but we're dealing with old ingrained problems. One interesting effort was the PROMPT-HF study. It looked at practical, cost-friendly ways to sort of flag HFrEF patients in the system, and then use electronic health records, EHRs, to give doctors automated prompts, reminders about needing to start or adjust GDMT. And that actually seemed pretty effective for initiating the therapy, making it easier for doctors to spot the need and act.
Okay, using technology prompts, that makes sense. But then there was another study mentioned, Reveal HF, and that sounds like it painted a less optimistic picture. What happened there?
Yeah. Reveal HF raises some tough questions, maybe about physician behavior. It showed something quite surprising and maybe a bit disheartening. Basically, it found no change in doctors' prescribing habits for heart failure meds or in patient mortality, even when the doctors were specifically given data about their patient's individual risk of death.
Wait, really? Even telling them this patient has a high risk, that didn't change prescribing.
Apparently not. According to that study's findings regarding prescription changes, you'd think that would be a powerful motivator, wouldn't you? But it didn't translate into action in terms of altering medication regimens in that context. So the interpretation from the research paper was that Reveal HF reflected this kind of dithering tendency, a reluctance among some physicians to fully embrace the GDMT recommendations and make sure dosages are right. It suggests just giving more information isn't always the magic bullet. And pulling back to the bigger picture, it really highlights that there's a myriad of factors blocking implementation. It's the facilities, it's the doctors, it's the patients themselves, adherence, access, all of it. It's a really tangled web.
So, okay, quadruple therapy is the new standard. But implementing it, it sounds like it brings its own set of challenges beyond just getting doctors to prescribe it. What are those, and where do we go from here?
Well, an inherent challenge with using 4 different drug classes is polypharmacy. That just means patients are on a lot of medications at once, and that immediately brings up the challenge of patient adherence. Can people realistically manage taking all these different pills at the right times every day? It's complex. It also adds complexity for everyone, potential drug interactions, managing side effects from multiple drugs, just the sheer burden of it all. And this directly affects how well the guidelines get implemented because, the best plan only works if the patient can actually follow it.
Right. So we're left with this tension, aren't we? We've got these amazing scientific tools, these drugs that can make a huge difference. But the full impact, the real transformation in patient health across the board, it's still pending, waiting for things to catch up in the real world.
That sums it up pretty well. Without getting that effective, optimal implementation of GDMT across a really large group of patients, clinicians, caregivers, everyone, we're still waiting to see the full power of these drugs reduce the overall sickness and death rates for HFrEF patients on a population level. The discovery, monumental. The guidelines, clear.
Yeah.
But building that bridge to widespread, equitable practice, that's the work that's still very much ongoing.
What really stands out to you after digging into all this, for me, is just such a stark reminder that the breakthrough in the lab is only step one. That journey to the patient, wow, it's incredibly complex. It's economics, it's habits, it's the whole system.
Yeah, and maybe for you, the listener, it's worth thinking about what does it really take beyond the brilliant science for these life-changing advances to actually change public health everywhere? How much is down to individuals, doctors learning, patients adhering versus needing bigger systemic changes?
Yeah.
Changes in how healthcare is delivered, how we ensure access, how doctors and patients even interact. It's a big question.
Definitely food for thought. We've covered the amazing science, the tough history, and those very real human factors. Keep thinking about how these big ideas actually meet the real world and the often long, complicated road they travel.